Hello, everyone. My name is Mikhail Bettis, and welcome to my diphtheria project presentation. So, for starters, we have the causative agent of the infection. In this case, we are talking about diphtheria, and its causative agent is Corynebacterium diphtheriae. Now, a picture of this is shown on the slide just to give a visual representation of what that might look like. Corynebacterium diphtheriae is a gram-positive, non-motile, non-sporulating bacillus that primarily infects the mucous membranes of the respiratory tract. It belongs to the genus Corynebacterium and is characterized by its club-shaped appearance. This pathogen produces a potent exotoxin, the diphtheria toxin, which is encoded by a bacteriophage and is responsible for the systematic effects of the disease. The toxin inhibits protein synthesis in host cells, leading to cell death and tissue damage. Corynebacterium diphtheriae can be cultured in laboratory settings using selective media, such as Tinsdale agar, where it forms a distinctive black colony due to the reduction of tellurites. Lastly, identifying and controlling the spread of this bacterium is crucial for preventing diphtheria, a potentially severe and life-threatening infection. Moving along, I have the epidemiology of diphtheria. Now, as we can see in the background, I have a demographic map displaying that diphtheria has a higher incidence in developing countries, and it's obvious that the Asian continent is mostly red, showing that there is a high concentration of diphtheria cases. Now, diphtheria remains a significant public health concern, particularly in regions with low vaccination coverage. Historically, diphtheria was a major cause of morbidity and mortality among children before the widespread use of diphtheria tetanus pertussis vaccine. Despite the success of immunization programs, outbreaks continue to occur, particularly in developing countries and areas affected by war or social distribution. The World Health Organization reports sporadic cases and localized outbreaks in parts of Southeast Asia, Africa, and Eastern Europe. Factors contributing to these outbreaks include lapses in vaccination coverage, population displacement, and inadequate healthcare infrastructure. The re-emergence of diphtheria in some regions underscores the need for sustained vaccination efforts and robust surveillance systems to monitor and control the spread of this potentially fatal disease. For my next slide, I have the transmission and prevention of diphtheria. For transmission, diphtheria is primarily transmitted through respiratory droplets when an infected person coughs or sneezes, releasing bacteria into the air, which can then be inhaled by others. Close physical contact and sharing items like utensils or towels can also facilitate transmission. In some cases, the bacterium can infect skin lesions, leading to cutaneous diphtheria, which is more common in tropical climates and among individuals with poor hygiene. Asymptomatic carriers can harbor Corynebacterium diphtheriae in their nasopharynx, contributing to the silent spread of the disease within communities. Understanding the modes of transmission is crucial for implementing effective control measures to prevent outbreaks and protect public health. Now, for prevention, the most effective measure for preventing diphtheria is vaccination. The diphtheria toxoid vaccine, often administered in combination with tetanus and pertussis vaccines, induce immunity against diphtheria toxin. Routine immunization schedules for children, along with booster dosages for adolescents and adults, have significantly reduced the incidence of diphtheria worldwide. In addition to vaccination, maintaining high levels of hygiene, avoiding close contact with infected individuals, and ensuring prompt treatment of confirmed cases are essential preventive strategies. Public health initiatives focusing on increasing vaccination coverage and educating communities about the importance of immunization are also crucial for the continued control and eventual eradication of diphtheria. My image displays the vaccines, which are, of course, crucial to preventing diphtheria. My next slide that I will present is the signs and symptoms of diphtheria. We have early symptoms, respiratory symptoms, systematic symptoms, and cutaneous diphtheria. For a sore throat, a severe persistent sore throat is often one of the first signs of diphtheria. A low-grade fever is usually mild, around 38 degrees Celsius. General malaise is fatigue and weakness and generally feeling unwell. Lastly, swollen glands are swelling of the neck glands, typically the lymph nodes. Next, we have respiratory symptoms. The pseudomembrane formation is a thick gray or white coating forms on the throat and tonsils, which can obstruct breathing and swallowing. We also have hoarseness, which is changes in voice due to inflammation and swelling in the throat. And we also have difficulty breathing. In severe cases may lead to respiratory distress due to the membrane blocking the airway. For systematic symptoms, toxemia is the diphtheria toxin can spread through the bloodstream, leading to symptoms affecting other organs. Cardiovascular complications can include myocarditis. Myocarditis can occur, leading to irregular heartbeats, heart failure, or death. Neurological symptoms can include nerve damage, which can result in paralysis, particularly of the soft palate, throat, and extremities. Lastly, cutaneous diphtheria is skin lesions. In cases of cutaneous diphtheria, infected wounds or skin ulcers are slow to heal and may have a grayish membrane. From the textbook, I have gathered an image that displays the pseudomembrane of a patient's throat, and this is figure 22.8. Now, I will discuss the pathogenesis and virulent factors of diphtheria. The pathogenesis of diphtheria begins when the Corynebacterium diphtheriae colonizes the mucous membranes of the upper respiratory tract. The bacterium adheres to the epithelial cells and releases diphtheria toxin, a potent exotoxin encoded by the tox gene, which is carried by a lysogenic bacteriophage. The toxin enters the host cells via receptor-mediated endocytosis and undergoes proteolytic cleavage, resulting in two fragments, A and B. Fragment B facilitates the entry of fragment A into the cytoplasm, where it inactivates elongation factor 2 through ADP ribosylation. This effectively halting protein synthesis, which leads to cell death and tissue necrosis. The local damage in the respiratory tract manifests as this formation of a characteristic thick gray pseudomembrane composed of dead cells. Systematic absorption of the toxin can lead to severe complications, including myocarditis, neuritis, and kidney damage. As for the virulent factors of Corynebacterium diphtheria, a highly potent exotoxin responsible for the majority of the disease's symptoms and complications. The toxin's ability to inhibit protein synthesis in host cells is the cornerstone of its pathogenicity, leading to extensive cellular damage and tissue necrosis. Additionally, the bacterium possesses several other virulence factors that enhance the pathogenic potential. Adhesions on the bacterial surface facilitate attachment to host epithelial cells, while cytospores scavenge from the host, which is essential for bacterial growth and proliferation. Furthermore, the bacteria produces enzymes like phospholipase D that degrade the host tissues and promote spread within the host. The combination of these virulence factors enables Corynebacterium diphtheriae to establish infection, evade host immune defenses, and cause severe systematic effects through toxin dissemination. As for my image, I have a virulence factors diagram displaying everything that I just covered. Last but not least, I have the diagnosis and treatment of diphtheria. The diagnosis of diphtheria primarily relies on clinical presentation and laboratory confirmation. Clinically, the presence of a characteristic thick gray pseudomembrane in the throat, along with symptoms such as sore throat, fever, and swollen glands, raise suspicion of diphtheria. Laboratory confirmation involves the collection of throat swabs or samples from the pseudomembrane for culture on selective media, such as the Tinsdale agar, which reveals distinctive black colonies mentioned earlier. Additionally, the ELITE test can be used to confirm toxin production by the isolated Corynebacterium diphtheria strains. And finally, polymerase chain reactions, or PCR, assays are also employed to detect the tox gene, providing rapid and specific identification of toxigenic strains. Early and accurate diagnosis is crucial to initiate timely treatment and prevent complications. As for the treatment of diphtheria, it involves a combination of antitoxin therapy and antibiotics. The diphtheria antitoxin derived from the horse serum neutralizes the circulating toxin and prevents further tissue damage, but does not affect the bacteria themselves. Therefore, it is crucial to administer the antitoxin as early as possible, ideally within 48 hours of symptom onset. Antibiotics such as penicillin or erythromycin are used to eradicate the Corynebacterium diphtheria infection, reducing transmission risk and preventing further toxin production. Supportive care, including maintaining airway patency, hydration, and monitoring for cardiac or neurological complications, is essential for severe cases. Additionally, individuals in close contact with the patient should receive prophylactic antibiotics and vaccination boosters to control the spread of the disease. Thank you.